Okay, so we are live right now. I'm Aparna. I'm one of your nerdy girls, and this is,
I'm Shoshi, another nerdy girl.
and we're so excited. We're here today with Dr. Meredith Matone. She is the scientific director at Children's Hospital of Philadelphia Policy Lab. She has written an excellent piece that we loved, and we really wanted to share with you about the idea of surveillance. So, we've heard so much about contact tracing and testing and how we can reopen successfully. We believe that those are two important cornerstones in controlling this pandemic. Dr. Matone has a very interesting perspective about surveillance, and we wanted to hear a little bit more about that. Shoshi?
So I think we'll just start by asking you what is surveillance in relation to contact tracing.
Great. Well, first, thank you so much for having me. It's really fun to be a part of the Nerdy Girl network today and talk with you. So surveillance, I think people think of as a scary word and often sort of have their own perceptions about what surveillance means. But really, in terms of public health practice, surveillance is monitoring. It's a foundational sort of tool in public health that's used to quickly identify outbreaks of illness or disease and monitor them within populations. And it happens in the background for the most part. Most folks don't even know what a sort of robust surveillance infrastructure we have in this country. And so one thing I like to say, because I think it's familiar to folks, is that foodborne illness surveillance is something that's always happening in the background. And it, for example, tells you when there's a salmonella outbreak and you should avoid the romaine lettuce at your supermarket. That's surveillance. So it's really not this sort of scary, deep state thing that we're proposing here. Surveillance can happen actively or passively. And in the context of COVID, right now we have a large sort of passive surveillance system that is in place that is part of our what's called the National Syndromic Surveillance Program. So syndromic surveillance is the term for a sort of passive surveillance program that really is just a collection of a data feed of hospital and outpatient encounters in laboratory tests that on a weekly basis are sent from health systems and laboratories to public health authorities at the local, state level, and to the Centers for Disease Control and Prevention. And so that is really what we've been relying on for COVID. When you hear sort of the CDC talk about our hospitalization rate, for example, our test positivity rate, what they're referring to is sort of within the paradigm of syndromic surveillance. Ideally, we would like to see more surveillance, and there are other opportunities to expand the type of surveillance that we're doing beyond surveillance of individuals who are ill, who have gone to seek care at health systems. And we know that the relationship between contact tracing and testing and surveillance is that they should operate in tandem, in a complementary way, and that we have an opportunity to use other types of surveillance like participatory surveillance, which allows citizens, the public, to report their symptoms in a timely basis that can precede contact tracing and testing, because we've gotten ourselves really into a bit of a pickle with our testing deficiencies, our testing delays, and the lack of a robust contact tracing sort of program nationally and at the state level for many states. And so we're really behind. And so now is the time to really think about how do we supplement our information feed with surveillance.
Wow. Okay. So a lot of this is already happening, it sounds like. And how would we, if we were thinking about really ramping it up in relation to contact tracing and testing, how would we do that?
So I think we would have a bit of a pivot. Certainly syndromic surveillance, we need to be monitoring who's engaging with the healthcare system, what proportion of visits are COVID visits, what proportion of lab specimens are COVID. That's foundational information that we need. But we can be more proactive and follow a model that has been really used and vetted for influenza called participatory surveillance. In Europe, for example, there's been research on participatory surveillance, which again, sort of the concept is that individuals can self-report their symptoms into a web-based application or another platform, or to a designated person, be it their employer or school. And when we've seen people start to talk about this with COVID a bit. And what this does is it allows for more timely information flow, because we know that not everyone with symptoms seeks healthcare. We know that healthcare is not accessible to everyone. And we know that we have significant testing delays with COVID. And all these things are giving us a really imperfect and incomplete picture of disease burden within communities, and disease burden within underrepresented and under-resourced communities in particular. And so what's cool about participatory surveillance is it's sort of a public service, and one that we can sort of give the power of information sharing to individuals. And it's a very low resource infrastructure that needs to be put into place. We have a participatory surveillance platform called COVID Near You that's available. And some folks are using COVID Near You right now, and states are sort of getting data dumps of this information. But I would say on a more broad scale, there's really not a lot of information about what participatory surveillance is, that folks can be engaging in this, and a lack of sort of state level leadership, I would say, for states really willing to embrace this and put out targeted communications campaigns to allow folks to engage in this in a robust way. And the other side of this, I would say, is for employers and schools. We know that many of them, as we talk about reopening, are preparing to do symptom monitoring. Symptom monitoring is participatory surveillance. And the real tragedy is that all of that data is just going to sort of live with the organization that is administering it. If we were to think in a more strategic way about how to get all of those large employers that are screening thousands of individuals for symptoms on a daily basis to feed that information more formally into county and state surveillance programs, well, then we'd have a way of having a much more robust and systematic picture to identify sort of signals of disease outbreak rather than waiting for healthcare data.
Wow, that is really, really interesting. And I think answered a little bit of our next question, Shoshi. Do you want to jump in and add on, Shoshi?
Yeah, sure. I was going to ask, and I really appreciate that you touched on, the fact that, people hear the word surveillance and it can kind of freak people out. I'm just wondering if you could speak to any potential unintended consequences or downsides or any privacy concerns that people might have.
Sure. So I think privacy concerns when people hear about information sharing are very real. And we have sort of an ethical obligation as public health practitioners and as a public health community to understand what we are asking of people when we ask them to voluntarily share information. I think some of the concerns around privacy get conflated with, for example, a few months ago, we were talking a lot in the media about contact tracing apps, for example, and phone-based or sort of web-based applications that monitored individuals sort of geospatially or monitored their contacts. And that is the utility of those and their privacy concerns, I would say, are separate from when we're talking about sort of surveillance in its most basic form. Surveillance really, the goal of surveillance is not to be a diagnostic tool. It's not to monitor contacts. The goal is really at a population level to be able to pick up a signal of a potential outbreak. And because of that, all we really need to know is where you are and what your symptoms are. And so, for example, with COVID near you, we need to know your zip code. If you'd like to participate sort of longitudinally, they have a text messaging based version, and you can enter your cell phone number. So for example, every 3 days, I get a text message that says, are you healthy or sick? I say healthy. If I said sick, it would tell me to go to a link where I would just click off my symptoms, and that'd be the end of it. And so it's really not a diagnostic tool. And so I think that that's very important and alleviates a lot of the privacy concerns. The other thing that's important to know is that we don't need 100% participation. We need very far from 100% participation. Obviously, more is better. But again, because we're trying to pick up a signal, we can have a utility in the use of participatory surveillance with low levels of community participation. And the other sort of, when we think about unintended consequences for surveillance, I really worry that our current system of surveillance that relies almost explicitly on healthcare encounter data, really the unintended consequence there is that we're missing communities that have very little healthcare engagement and or individuals who are mildly symptomatic and are not seeking care. And so again, that leaves us with an incomplete picture, which I think can contribute to disparities. And so the opportunity with participatory surveillance is that it's a low resource, easily accessible way to get a more complete picture so that we're not leaving people behind. And when we think about our current sort of testing resource constraints, what a more broad application of surveillance would do would allow us to save our testing resources for areas where we've detected a signal that there might be a possible outbreak happening, or sort of a priori designate and focus our testing on communities or facilities or occupation that are at higher risk of COVID exposure and high risk of COVID spread. And that's really where we want to focus our efforts. But we've lacked a coordinated strategy that pairs surveillance with testing and contact tracing. And we've only focused on testing and contact tracing and haven't allowed ourselves to create a targeted infrastructure because we're worried about how we can sort of dilute our resources across everyone when that may not be necessary.
Just as a follow-up question for our viewers and our followers, can you tell us a little bit more? I know this is a little nuanced, but about why or when contact tracing works, given circulating levels of disease, for example?
Sure. So we have a really rich evidence base on contact tracing in public health. It's been around for a long time, and internationally, we've really perfected, I think, models of contact tracing and seen a lot of success with diseases like Ebola, tuberculosis, HIV. And what we know is that contact tracing is most successful when we have lower levels of circulating illness and when the period of infectiousness for a particular illness is short. And I think this makes intuitive sense, right? Contact tracing is hard. It requires that you identify someone, ideally very early in their sort of disease course, that you and they can figure out who their contacts are and how to reach them. And then in a very timely fashion, you can reach everyone and sort of successfully create a contained social bubble. That's expecting a lot. I mean, the process itself is very difficult. And then we know also on the back end, once you sort of meet the milestone of reaching everyone who you think might have had an exposure, that actually complying with a quarantine is very difficult. And particularly in individuals who are living in circumstances that have structural inequality, you know, it may not be on the table to not get a paycheck for 2 weeks and sit at home, or to find a place to socially isolate, or to not go out into the community to get a meal. And so I think we've seen a lot of those challenges, and we would need to rely, I think, less on contact tracing if we had a more intentional strategy for monitoring and focusing our testing resources on those who really need it. And as we've let the sort of pandemic rage out of control a bit, I don't really see how we can meet the demand that we have for contact tracing successfully.
Thank you. Could you tell us a little bit about, and tell our followers a little bit about other places where this has worked, current or in the past, other parts of the world or localities, just for reference?
Sure. So in Europe, as I mentioned earlier, they have for a number of years had a participatory surveillance system for influenza. And they use this data to get sort of a more complete picture of their influenza activity within communities, and also have found that they're able to get more expeditious information on when flu might have arrived within a particular community. Because for all of the reasons we mentioned, if I'm reporting my symptoms and not waiting for you to get a weekly report that I actually made it to a healthcare facility and was seen for flu-like symptoms, that there's a sort of faster, more real-time component to that. Some of these platforms have transitioned for COVID, and I was just reading up and following up on Australia, which also has an influenza monitoring program that they've transitioned to also include COVID, and they have about 130,000 users, regular users of this participatory surveillance system for COVID. And what they have seen is that in pairing their participatory surveillance data with their sort of syndromic healthcare data, they found that there was a lot more mild illness circulating within communities than they would have otherwise known about, and that their sort of healthcare presentation rate, so the rate at which people who are symptomatic were actually showing up to healthcare facilities, was lower than they had anticipated. So again, it gave them a more complete picture of circulating illness. And while 130,000 people is a lot, it's certainly not, 90% of the Australian population, and they still were able to sort of gain valuable insights.
Wow, thank you so much. I know that I have learned so much so far. I want to ask Shoshi if you have any other questions, or Dr. Matone, if you would like to share any last words with our followers.
Go ahead, Dr. Matone.
Oh, I was just
no, it's okay.
Yeah, no, I mean, I just really appreciate having this conversation. And I think as we think about reopening, I hope that we don't forget about the opportunity that we all have to advocate for the sort of testing strategy that will be a better use of resources, and that the symptom monitoring that we all are going to be engaging in as part of our employment, maybe as part of our children's school, that we have an opportunity to advocate, that our sort of public health leaders think thoughtfully about how they might be able to use that data.
Wonderful. Shoshi, anything else to add?
I've learned a lot. I think this is such an important conversation to have, to be thinking about how, reopening, there's still going to be a lot of things that are different, and a lot of ways in which we can think about, like moving forward while implementing, really important new innovative, I want to say, use the word surveillance. We've been talking about surveillance, but surveillance techniques to really see, like how are we doing with our reopening, and how we can do better. So I really appreciate your time and learned a lot.
Yes.
Great.
And I'll say thank you to all our viewers for following. Thank you, Dr. Matone, for this really insightful conversation, and further thought for us to continue thinking about how to best leverage our resources as we move forward towards reopening and as we face the fall. So I'll say bye to all our viewers. Stay safe and stay sane.
Thank you so much.
1 second.